panel of expert, learned audience. Assalamu alaikum. I am Dr. Shamim Chowdhury from National Heart Foundation Hospital. Is going to present my case. Is a 55 years old gentleman with recurrent palpitation. My case, Mr. Y, 55 years old patient, came to our outpatient department with the complaints of recurrent palpitation. He had history of non-steal elevation MI and SBT 1 year back, and he underwent coronary angiogram in outside center, which revealed normal coronary arteries with sluggish flow. He was still symptomatic despite medical management, and had his echocardiogram was normal. This is his baseline ECG that's showing the short pair interval with the delta wave and incomplete RBBB. So, in this scenario, the patient was with pre-excitation on ECG and symptoms and documented arrhythmia, and the EP study and ablation is the guideline recommendation according to the ESC 2019 guideline. So we will send the patient for the electrophysiology study, and this is the baseline intercardiac electrogram during the electrophysiology study. And during the intercardiac electrogram, during tachycardia showed short HV interval with varying degree of change in morphology suggestive of engagement of accessory pathway with earliest atrial activity in CS 910. And this is the reproducibly inducible regular narrow QRS tachycardia during atrial stimulation. So now the question is to the panel of experts and to the audience to localization for the pathway. Usually we do a lot different algorithm for the localization of the pathway. However, the most one that is been approved by all the European and American guidelines. That is the ERUDA criteria for the localization of the accessory pathway, and that is that they will see the whether when the lead one whether there is a positive, negative, or negative. If there is no, then we should go to the lead 2. If the lead 2 there is no negative deflection, then we'll go to the B1. And if the B1 there is a negative and or isoelectric, then delta wave, then we will go to the septal. That is septal, and after that we'll go to the lead ABF. If there is negative or isoelectric delta wave, then it is a posterior septal pathway. So in our case,
we can stop here, sir, but we can continue another with discussion maybe. Yeah. So, Firoz, you can discuss, then can come back the presentation. It's good, I think so. How to localize? So, back up the slide. Back up the slide.
This was the first ECG given to you.
You can discuss this ECG,
This
then can
ECG,
come
sir.
back continue.
Tell me, how will you make that it is not an AV RT, it is an AV RT?
It's good.
Because
Time 10 minutes off.
no, this is the first ECG. The patient
first.
came with this rhythm. Tell me the first important thing. Why it is not an AV RT? First is tachycardia ECG, which you are showing in the EP lab. For an audience, it will be important to know. Yes.
This one.
No. For tachycardia ECG, just show the yes.
Yes.
Now tell me, how will you approach this tachycardia ECG?
Yes, I will see the RP interval and PR interval. If the RP interval will be
Go stepwise. 1, 2, 3, 4. 15 seconds. Narrow QRS
regular
tachycardia
tachycardia.
given to you. How will you approach?
First narrow QRS regular tachycardia. Then
First you will calculate the heart rate.
heart rate.
It
Yes.
is tachycardia or not. Second,
Second, I will
it is
see
narrow or
whether the
wide.
sinus, wide.
What is the definition?
What is the what?
What is the definition of narrow and wide?
QRS more than 120.
120. More than 120. It is not equal to 120. So if more than 120, it is a wide tachycardia. Third, regularity of the tachycardia. Regular or irregular? It is regular. Fourth,
Fourth, then I will go to the whether there is sinus or
dissociation, AV dissociation or VO dissociation. Fifth, fusion beat, or in a
Absolutely.
narrow QRS also there may be a VT. Which VT? Fascicular VT. Very good. So see, in narrow QRS also that fusion beat or capture beat. Sixth,
Sixth, there will be the
P wave. You should see the P waves. Where is a P wave? If there is no P wave identify, then go to lead V1. If there is a notching in the terminal part of QRS, it suggests more AV and RT, just terminal part. It suggests that probably the VA interval is too short.
Too short.
So in this ECG, I will make differential diagnosis of AVRT more, because if you see the lead V1, and inferior lead, there is no slurring in the end of QRS complex. Okay, it's an AVRT.
Yes.
Then go to localization after cardioversion. Can you localize pathway during tachycardia ECG? Yes or no?
Yes, sir.
No. Only you can localize sometimes.
Sometimes.
Tell me one.
Sometimes I can.
When you are able to see the P wave.
P wave, yes, sir. When I'll be P wave in the lead 1, it will be negative, then it will be the left-sided pathway.
So you have to go approach wise. Always go with approach wise. And when you, and as I think the localization algorithm which you are presenting, I think it's the simplest algorithm.
Yes.
Don't go to the complex algorithm. Even if you don't read ECG in 1 month, you will forget all the algorithm. So the approach should be this algorithm. I believe is the most simple algorithm. And it doesn't matter for a cardiologist in the periphery, whether it's a left-sided, right-sided, inferior, posterior. It only matters for electrophysiologists. If it's an interoceptor pathway, you should be less aggressive in doing it. So localization of pathway has no relation as far as clinical outcome of these patients are concerned. So this message should be go to the general physician. They don't afraid it's a left-sided pathway, it's a right-sided pathway. Thank you. Please carry on.
Now you can carry.
So in our case, there is a, in the B1, there is a negative or isoelectric delta wave, and if you go to the ABF, there is also a negative delta wave. So this could be a case of right-sided posterior septal pathway. So in our case, our diagnosis was right-sided posterior septal pathway. Probably as the in ABF, could be in the tricuspid annulus. So radiofrequency ablation was done in the CS os. Within 20 seconds of accessory pathway disappeared after single radiofrequency ablation energy, and post RFA 12-lead ECG shows no pre-excitation and the memories and inferior leads. An adenosine challenge test was done and there was no accessory path was evident, and vigorous stimulation protocol with isoprenylene failed to induce any tachycardia. And this is the ECG during discharge, showing there is no delta wave and sinus rhythm. So take home message: the management of pre-excitation depends on its nature of presentation. Localization of accessory pathway is key to successful EP study and RFA. Among the various algorithms for localization of accessory pathway, ARUDA criteria is the well accepted among all the societies, including the European and American Rhythm Society. Here I present a case of WPW right-sided posterior septal pathway, which is managed successfully by EPS followed by RF. Thank you all, and thank you IPDI for allowing me to present my case.
What will you do?